When I was a general medical intern in Karachi, Pakistan, civil hospital, I was referred a young girl, 20, 21 years of age, and she presented with somewhat like a frozen state in a semi-catatonic state. I examined her. I did a complete neurological exam, and I diagnosed her as having psychogenic catatonia. She was referred out to one of the fakirs, which generally are found around the shrines in that area for further treatment. Now, these fakirs are the faith healers. They use traditional treatments, age-old treatments, to help in exorcism for that matter. Unfortunately, we were not able to get any follow-up on this young lady. Now, this is not unusual. This is what happens in many of the developing world, especially in the rural areas. For any psychological, behavioral problems, majority of them are treated by these spiritual leaders, spiritual treaters in the community. So I came from a background where psychological or behavioral problems were not even considered a medical illness in that respect. Early 1980s, I came to California. I ended up at Stanford, working in Carl Pribram's lab, taking care of a group of monkeys, grooming them, feeding them, and cleaning after them. That was, by the way, amazing experience. And I'll come back to it. Why monkeys in the first place? Monkeys' brain is very similar to human brains. My role was also to condition them in terms of operant conditioning, placing leads because of my surgical skills, and then tracing them with different changing behaviors. You know, initially, I was very discouraged, very disappointed, and maybe even depressed. And the reason was, here I was back home, a high-functioning ophthalmologist. And now, here I was taking care and cleaning up the cages of these monkeys. But I will tell you, there was one day of the week which was remarkable, which was Tuesday morning, our research meeting. The discussion that we used to have, the experiments and the relationship of the behaviors, the link between these neuronal tracts and some of the behaviors that we see was an eye-opening for an eye doctor, and I never looked back. So let me take you back a few years, especially on the clinical side. Predominantly, the treatment of behavioral problems, psychological problems, were dealt by psychotherapy or psychoanalysis. Now, Freud was a genius. Freud, the founder of psychoanalysis, presented his vision, presented his ideas, his theories about the link between the mind and the brain. He expected the people who followed him would further explore it. So his contributions to psychiatry, to psychology, are amazing. What is unfortunate that although he talked about dream analysis, but we were not able to link these dream analysis to the brain circuits, to what is happening underlying into the brain as far as some of these dreams are concerned. After my stint in the West Coast, a few years, I came to the East Coast for my neuropsychiatry residency. And some of you in the audience who have been through that, it is a boot camp. You are thrown in inpatient, you are thrown in outpatient, and even for us at the state hospital. Now, when I mention state hospital and this inpatient, these are the worst of the worst and most difficult of psychological behavioral patients, subjects that I'm talking about. By this time, we also start understanding that majority of the psychological, psychiatric behaviors were familial. Familial runs in the families, and there is a genetic underpinning. What happened with that, there was this understanding that this may be related to neurochemical imbalance in the brain. That led to an explosion of medications, the explosion of drugs trying to help some of these behaviors. There was antidepressants for depression. There were anxiolytics for anxiety. At one point, there were 36 different anti-anxiety pills available in the market, many of them over the counter in that respect. So, even what happened with all of this, with all use of drugs and medications, that we almost became dependent on these medications for all our behavioral, psychological, emotional needs. We became a Prozac nation. But all these medications are not bad. As a matter of fact, it helps majority of our patients in combination with psychotherapy and other forms of treatments, as you heard earlier. But what to do for those who do not get better with medications or with psychotherapy? A biopsychosocial model. There was a very interesting study led by Dr. John Rush. I was part of it, called STAR-D. STAR-D is one of the largest, about 4,041 subjects in real-world setting. It looked at different steps of treatment. First step, a single antidepressant. Second step, a combination. Third step, in combination with psychotherapy. Still, there was a number of patients who were not getting better, relapsing. And it is this very depressed, severely, somewhat melancholic patients that I will talk to you about. So here we go. While I was thinking about this group of patients, those who were so refractory, I reconnected back to my days at Stanford. After all, brain is a digital organ. It has neurons. It has more than 85 billion plus neurons, which are connected to each other. They form networks. They form neural circuits. They form tracks. And these neural circuits and tracks, now we had the technology, we had the neuroimaging technology that we could look into it. One of my colleagues in the audience, Dr. Durasamy, we would sit in front of MRI scans, looking at it for hours, measuring some of these structures and tracing these tracks. But even then, what to do about them? And at this point, one of our colleagues here at Duke, Dr. Holly Lisenby, who was the chair of Psychiatry and Behavioral Sciences, thought, can we modulate, can we stimulate some of these neural circuits? And one of the things that we decided to do is, can we apply magnetic stimulation? Why magnet? Because magnetic fields are very benign. And magnetic fields can be focused in that respect. So we tried that. And we did a clinical trial. Based on that clinical trial, FDA approved transcranial magnetic stimulation in 2008. Since then, many more of these magnetic stimulations were approved, including STMS, Deep TMS, and even MST is being considered. So, where do we go from here? What we realized that even then, some of these melancholic, some of these severely depressed patients were still suffering. Part of the reason, the obstacle we faced with these on-the-surface stimulation was that the stimulation was not deep enough to affect the deeper structures of the brain, like the limbic system. Limbic system is considered to be the seat of human emotions. In the meantime, the technology has improved. Surgical technologies have improved. Our colleagues in neurology and neurosurgery was collaborating with each other to treat some of the most refractory, for example, Parkinson's disease, targeting very specific areas of the brain, the nigrostriatal area, and helping some of these patients. What we found that many of these patients would get better. They're better, the tremors would get better, but some of them, it won't. But even those who did not get better their tremors, their depression, if they were depressed, would get better. That led us to trying to look into using DBS for those kind of refractory severe patients. So I started my talk telling you about the catatonic young lady who came to see me in Karachi. I want to tell you more what happened with DBS. One of our earliest patients that I treated was a 40-year-old OBGYN, had become so depressed that has become non-functional, gave up his practice, is completely disabled. We gave DBS, and within months, he started showing improvement in his mood and his functionality. I am very happy to report, just within the last 2 months, he came back to us. He wanted his batteries replaced. He's fully functional. He's back to practice. He now has a family. So, my friends, along with all this, you most recently must have heard about Elon Musk, Neuralink, placing these neuronal chips into the brains. And I know a lot of people would be skeptical about all of this. But remember, with the advancements in AI, high tech, we are at a point we cannot avoid it. The tsunami of high tech is here, and we can adopt it or we can leave it. And it's time that all these disciplines come together to help some of our most vulnerable, some of our most distressed people with psychological problems with each other. I hope one day we can stand here and say that after Prozac, there is hope. Thank you very much for your attention.